Hi, so for a cardiac assessment, you would first want to start out with a patient uh, history, their background. A lot of times, their age, gender, their personal family history, their nutritional intake, their extracurricular activities, such as like smoking or drinking, can really affect how somebody's body will be or their risk factors for developing certain diseases like um, coronary heart disease. So when you're inspecting somebody, you first want to look at their color. Um, a patient shouldn't ever be blue, or they really shouldn't be pale. Um, you want their skin to look kind of pink. Um, it should be warm and not like super cold. So a lot of times, if you have decreased blood flow, your body's going to be colder. Um, yeah, somebody that's cyanotic, that's a really bad problem. They're either not getting enough oxygen in a short amount of time, or it is a overtime kind of thing. So a lot of times you might see it in people's fingers, babies and stuff like around their lips. Um, so yeah, when you're checking their extremities, again the color, but you also want to check for skin turgor, which is also more of a fluid status thing. But if they have vascular changes, then they might have some muscle fatigue, discomfort, pain, clubbing of their fingers, which is a uh, chronic sign. So if this person has clubbing in the fingers, their fingers have really not been getting good blood flow in a while. I would look for edema, um, which has to do with like fluid accumulation in their body. So if it's bilaterally, like especially in people's legs, if it's both of them, a lot of times it has to do with heart failure. If it's more localized to one extremity, like if it was just one leg, guarantee it's more of a venous obstruction problem, so like a thrombus. Um, these people are going to have a lot of pain in that extremity, so we don't want the thrombus to move. We don't need to move. We don't want it to move to your lungs and become a pulmonary embolism, because that would be bad. You also want to check people's capillary refill when you pinch their finger. It should blanch back within 3 seconds. If it's not blanching back in 3 seconds, they're going to have a really low tissue perfusion in their fingers. Something else you can look at is hair growth, more so on their legs or their arms, not exactly their head. If you don't have as much hair growth, I know women, we shave our legs a lot, but if you can notice that there's no hair growing there at all, guarantee it's a circulatory problem. Um, if you're getting good circulation, your hair's going to be able to grow. So, also, if a patient has recurrent ulcers or they're chronic, really bad, never getting better, especially diabetic patients, that's a circulatory problem too. Um, when you're doing the cardiovascular assessment, you're going to take the patient's blood pressure. Normal, 120 over 80. Um, above or below, obviously, hypertension, hypotension. A lot of times, people can get orthostatic hypotension, which can be related to certain cardiovascular drugs that they're on, blood volume decreases, prolonged bed rest. It's really going to show, and that patient's going to get like really dizzy and everything. So, pulses. Jugular vein, which is on the right side of your neck, you want to look for that. Normally, if somebody's laying down, you can see it distended a little bit. Ooh, excuse me. But once that person sits up or is standing and walking around, you should not be able to see that jugular vein. So, somebody that has heart disease, um, heart failure, that jugular vein is always going to be distended, and it's not pretty. your pulses. You're always going to check your pulses. So you have your temporal ones, which are on the side of your head, the carotid arteries, which are on the side of your neck, brachial, which are halfway down your arm, basically in your elbow area where you bend your arm. Radial, which comes off your thumb, this side. Your ulnar comes off the other side, more towards your pinky. Popliteal, which is behind your knees. The posterior tibial, which is on the inside of your ankles. And then the dorsalis pedis, which runs basically between your great toe and the first one. So all of these pulses should be equal, the rate that they run, the rhythm. They shouldn't be, one shouldn't be bounding and one shouldn't be, really weak. So if we have weak pulses, could be from hypovolemia, aortic stenosis, your decreased cardiac output. If you have a bounding pulse, you're going to have a high cardiac output, or sometimes you can have like a more sympathetic activity, so you can be in a lot of pain, have a fever, be having an anxiety attack. All of those things are going to change your heart rate. When there are certain ones that you want to auscultate. So your carotid artery. For one, when you're checking them, you don't want to press them at the same time because you're cutting off blood flow to the person's brain. You don't want to massage them either because this can stimulate your vagus nerve and cause a drop in your blood pressure. Your heart rate can cause syncope. So when you're feeling these carotid arteries, if they're absent on one side, there could be an arterial occlusion, so some kind of blocking that blood flow. Or it could be some kind of stenosis, so your blood vessel is narrowed, or there's something in it that's making it narrow. A lot of times atherosclerosis or some other kind of arterial disease is what's causing the problem. So with your stethoscope, you would want to listen with the bell portion over the carotid arteries, one at each time, obviously, and auscultate for bruit, which is like a swishing, blowing kind of sound, because all this blood is trying to pass through the vessel, but the vessel is narrowed, so there's a lot of pressure from your blood, but the hole is only this big, kind of thing. So you would also want to listen for bruits in your abdominal aorta, which is more down here in your abdomen, obviously. When you're listening, having to do with your heart. If you're inspecting, you really shouldn't be able to see any kind of pulse. If anything, it might just be towards the apex of your pulse, which is down here, your mitral area, where that's normal because that's the point of maximal impulse. So when you're auscultating, listening with your diaphragm, you're going to listen for your aortic, which is on the right side of your body, second intercostal space. So that's where you're going to hear the aortic valve close the best. Then the pulmonic valve is going to be second intercostal space to the left of the sternum. Tricuspid is going to be about the fourth intercostal space down, just left of the sternum, and then the mitral valve, you're going to hear the most fifth intercostal space down, but more mid-clavicular line. So your clavicle up here, basically right down, and that's where you'll hear the mitral valve, the easiest. So your heart sounds, you should normally only hear 1 and 2, which is the lub-dub. And S1, the lub, is the closure of the mitral and tricuspid down. So your pulmonic and aortic valves are opening, which is your really big squeeze. Um, best heard over the apex of your heart, so towards that point of maximal impulse. It can intensify with exercise, hypothyroidism, mitral stenosis, but it can also decrease and not be as prominent with mitral regurgitation or heart failure. Your S2 sound is the closing of your aortic and pulmonic. So what's opening is your mitral and tricuspid. So it's going to be a higher pitch, but it's going to be shorter. Best heard at the base of the heart, which is your aortic area, which is on the right side of your sternum. You should not really be able to hear any other abnormal noises. Gallops. Mitral and tricuspid valve, they're not closing at the same time. So one is going to close, and then the other one's going to close shortly afterwards. You're going to hear a boom kind of thing. It's going to sound more like a horse galloping. Excuse me. If you hear an S3 sound, it's called a ventricular gallop, which can sometimes be normal in people less than 30, but anything over that, it can be a problem. People that are also in their third trimester of pregnancy, you can hear it sometimes. The sounds more like a Kentucky sound. It's a premature rush of blood into the ventricle that's stiff or dilated. So in older people, it can be an early sign of heart failure. An S4 sound, which is an atrial gallop, occurs before the S1, so it sounds more like Tennessee, which is atrial contraction pushing against a ventricle, but that ventricle is not accepting blood, so can be caused hypertension, anemia, ventricular hypertrophy, a PE, an MI. So when you're listening, you're also listening for murmurs, which is turbulent blood flow through the normal or abnormal valves. You want to rate it by its intensity, the loudness, which is related to the rate of blood flow through the heart, or the amount of blood that's being regurgitated back. It's not pushing all the way through. Or you can possibly hear a pericardial friction rub, which you should never hear. Basically, the pericardial sac can be inflamed, can have an infection, you can get pericarditis. Basically, you're going to hear that rubbing when the heart is contracting, and none of those things are ever good. So, that's basically your cardiac assessment.